right, clean freaks, welcome back to another episode of Sterile Horizons, Advancing ASC Excellence, a special Beyond Clean series we're doing, sponsored by Solventum. I'm your host, Bobby Parker, and in this series, our aim is to detail both the challenges and the opportunities for instrument reprocessing in the ASC setting so that you can provide the best quality of care for our patients, every instrument, every time. Today's episode is titled Beyond the Hospital, Unique Sterilization Challenges in the ASC. So we'll be asking questions like, what is the difference between a hospital and an ASC? Is an ASC just a little hospital? What's unique about it? Also, what's unique about instrument sterilization and reprocessing in that ASC setting? Are there any unique challenges there that maybe we're not as familiar with in the hospital environment? Well, to answer these questions and more, we've brought in former HSPA President Monique Jelks with her many years of experience in the perioperative environment, both in the OR setting and in sterile processing. So I suspect this is going to be a great and spirited conversation. If you've ever talked to Monique before, you're in for a treat. Hang with us. We'll be right back. And joining us now in studio is Monique Jelks, Director of Sterile Processing out there in the Northeast. Monique, welcome to the show.
Thank you for having me. Thank you so much. It's always a pleasure to talk about sterile processing.
Yeah, absolutely. And Monique, you've been in the industry for a little while, done a lot of speaking. I'm sure that you need no introduction, but for those who haven't heard of you or haven't listened to you speak before, why don't you give us a little bit of an introduction about yourself, what you've been doing in the industry, and why you care so much about this beautiful world of sterile processing?
Yeah, I always need an introduction. I meet new people all the time, and I don't believe that everybody knows who I am. But that being said, let me tell you, this year, December, I will have been in perioperative services for 35 years. So I started my career as a surgical tech, and I worked as a surgical tech for 17 years and was voluntold to go help sterile processing. The manager of sterile processing abruptly quit his job. He just could not take the pressure that the OR was putting on him, and he abruptly quit. We are really good friends right now today. He's retired. He lives in Indianapolis, Indiana. And during that time, I was finishing my bachelor's degree in business, had no intentions of maintaining a career in the healthcare setting. I was doing community work, nonprofit work, and I was going to use my degree to grow my 501c3. And as fate would have it, I got voluntold to go to sterile processing. I used that opportunity to write my last paper for my class in school and never went back to the surgery department. I got to sterile processing. Long story short, took to it like duck to water. I saw so many issues with my own colleagues from the OR and how they were treating the staff in sterile processing, how they were delivering trays, the unbelievable demands that they were making, unrealistic. And right away, I just jumped into action and started to bridge the gap. Now, I created a lot of enemies in the OR because, remember, I was told to go fix it. I was known to be a part of problem solving and resolving issues in the OR. That's why I was appointed to go fix, right? And so what I discovered is the problem wasn't the sterile processing department. And so I started doing a lot of education. And that education landed me on a big stage in Nashville, Tennessee. I believe that was in 2017. Got on stage, did a presentation, and everybody loved it. And it was just a hardcore presentation about the reality of our work, like how we work every day and what our challenges are and how we need to get along together with the OR. And it was a lot of OR people in that conference in Nashville, Tennessee. It was then Isham. So long story short, I got invited by a lot of different companies to come speak, and then was nominated to the board of then Isham. And my board time was the time that they had prepared to change the name from Isham to some other name. So I was on the board at that time, and I'm a fixer. I'm a work hard. I'm a very dedicated person when it comes to creating improvements. And so we changed the name, and I was a part of that board initiative. Then I got nominated to be the president of HSPA. And I literally just last year finished my term in, this year, St. Louis. Ended my term as immediate past president. And now I am free as a bird to talk, to go work in industry, to remain in the hospital, to do all kinds of things. So I'm excited. I'm excited that I can still be relevant and still talk about sterile processing.
Well, thank you for that introduction, and you covered a lot of what I wanted to mention if you didn't say it. So thanks for having the humility to walk through some of that. I also want to appreciate the tenure that you've had in perioperative services, because we're going to lean into that today as we're talking about ASCs. Having been around for a little while in the industry, you've seen a tremendous amount of change,
Absolutely.
Not only in just how sterile processing works, as we often talk about, but also just how healthcare delivery happens as we're looking at ASCs. One more comment before we get there, though. You cracked me up with that comment of being a fixer, of coming from the operating room into sterile processing. Made me think of the third movie from Star Wars. You know, you were the chosen one. You were supposed to go and destroy the Sith, not become one of them.
That's right. That's right. That's right. That's right.
And so we're not doing the OR-SPD collaborative relationship talk today, but there is a lot to be said there about walking in somebody else's shoes and learning that, you know, the person you're pointing all the fingers at isn't always the problem. But anyway, let's talk ASCs today. We've been working through this series about delivering healthcare in kind of a smaller environment in the Ambulatory Surgery Center. So why don't we start right there at the top with some definitions? Can you walk us through what is an ASC, and maybe more importantly, what do most people get wrong about ASCs? What are the big misconceptions?
Okay, so let me tell you, an ASC is an Ambulatory Surgery Center. That's what it stands for, Ambulatory Surgery Center. Ambulatory means you can get up and walk out after your surgery. You're ambulatory, right? So you're able to get up and walk out after your surgery. You're not going to be laid up in the bed, convalescing, right? Rehabilitating. You're going to walk out after your surgery is done. That's what ambulatory stands for, Ambulatory Surgery Center. So 35 years ago when I entered surgery, and I say 17 years ago when I entered the world of sterile processing, when I first became the leader of sterile processing, I had one ambulatory surgery center and one main operating room sterile processing department, right? Let me tell you, back then, ambulatory surgery centers were nip tucks, just a little plastic surgery, a little ophthalmology, a little ENT. You got your nose broke, we're going to fix it. You got cataracts, we're going to fix it. Little nip tuck, you get up and walk out. And so that's what it was all about for years. And they would just pump out a lot of cases, nip tuck cases, and you're done. The procedure would take about an hour or less, and you were out the door. Right? Now, ambulatory surgery centers have big cases, total knees, total hips. They're taking all of 30 minutes to have these procedures, right? Wheels in to wheels out of the operating room is about an hour, hour and a half. So now you're seeing big cases, massive amount of instruments because of the robotic industry, because of robotics. Ambulatory Surgery Center has taken on a whole nother beast. So although it has grown, the complexity of it mirrors and matches that of a big hospital setting. So I say one of the misconceptions is that, oh, they're just doing a little bit of something. No, they're doing some big procedures. And although the patient does not have to spend a night in the hospital, it is just as critical as major operations that are taking place in major hospitals.
That's well said. We've got the same patients that need to be cared for both in the hospital setting and in the ASC setting. So we need that same standard of care. One of the challenges, though, is the question of resources, because at the hospital, we've got a lot more space, a bigger OR driving revenue, sometimes a participating healthcare network. But in this ASC that is often in a smaller footprint, sometimes financially independent as well, we can struggle a little bit with those resources. I'm curious, in your experience, have you seen any of those challenges of that smaller constraint, and particularly kind of the financial constraints of working in the ASC, get in the way of being able to do a good job with all that complexity that we're dealing with?
Let me tell you, I've only had 4 AFCs that were under my leadership that were not owned by physicians. So I've only had one encounter with one ASC that I had to work alongside to support that was owned by a joint venture group, a group of surgeons that own this facility, right? But even whether the surgeons own the facility or the hospital owns the facility, the size and the resources is still the same. Hospitals tend to have a little bit more resources because they're connected with major supply chain entities, right? When the surgeons own it or small investment groups own it, they tend to minimize the resources and get by with the bare minimum, right? There's various reasons for why that's happening. What I find to be very complicated in these settings is that sterile processing, just like in a big hospital, just like you're in a hospital setting versus an ambulatory surgery center, both of these places are always the last to get the funding and the resources needed. It is the same at both facilities. The hard part about the ambulatory surgery center is that you might have at best 2 people working. Some of these facilities is one person. They do all of it: decontam, assemble, and sterilization. And if the cases are running late at the ambulatory surgery center, you don't go home, because guess what? Those same trays are needed for the next day. So it's much more complicated when it comes to staffing and the total number of trays you have against the number of surgeries you have. It's a harder productivity to manage in a surgery center than it is in a hospital setting.
For sure. And when your whole workflow in sterile processing is 1 or 2 people, the impact to the facility when that one person or one of those 2 people is either on vacation or out sick is tremendous. That's half your workforce just called out sick if that person is missing. It reminds me of a surgery center that was affiliated with the healthcare network where I was managing as a sterile processing department. And thankfully, we were able to train up a couple of folks to be able to work out at their facility so that whenever they had that issue, they could call on us and we'd send somebody out there to fill in from a staffing perspective. But that did cause me to wonder and question for those independent physician-owned surgery centers that maybe don't have that. There's a real not only staffing challenge, but also training challenge. If the plan is we're going to have surge techs fill in for when our reprocessing gal is on vacation, how do you keep up with the competencies for that?
There is a whole quality issue when it comes to that. And as you know, you don't have to be accredited by any facility. Any or agency, right? You have to invite the Joint Commission and you have to invite a regulatory agency for the ambulatory surgery centers to come in. So if you're the joint venture, you can pick whatever accreditation agency that exists out there. You don't have to choose the gold standard, right? And when that happens, you can make up your own standards. You can make up your own processes. And so you're untrained, uncertified, lacking knowledge surgical tech will come and build the trays, minimizing inspection points, minimizing the standards of how you place certain items in a tray, how you wrap certain items in a tray, all in the name of we just got to get it done because it's needed for the next day. And now quality goes down the drain. And if anybody is out there listening and they say, hey, we got some surgical site infections and we can't figure it out, you might want to take a look at how you're delivering the services in sterile processing, right? There's plenty of ambulatory surgery centers where the surgical techs are also doing everything. They scrub the cases and then they go and they do it. Let me tell you, we're talking about ambulatory surgery center, but our endoscopy units are the same way. So endoscopy is the same, right? So you have endoscopy facilities, right? Well, the technicians are doing the procedures with the doctors, and then they're rotating to manage the reprocessing, high-level disinfection of the flexible endoscope. It's the same type of mentality, but are these individuals truly trained to do so, right? And are they keeping up with the latest standards, latest recommendations?
Yeah, that's the question. It's not a question of skill or capacity. Certainly that could be done by someone, but it is more a question of organization and training and competency. Are we doing what we need to do to make sure that that person's doing it appropriately? And maybe the model was more common back when there weren't as complex of instruments coming through the department. But gosh, trying to know which of these crazy orthopedic instruments come apart into three different pieces, trying to get these orthopedic instruments that all the different pieces have to come apart, all the robotics instruments have to go through the ultrasonic cleaner and how we get them appropriately cleaned and set up. So much complexity. We just have to be thoughtful about who's staffing that room. All right, you're tempting me here, Monique. We've got an episode coming up on accreditation in ASCs, and I really want to dive headlong into this topic right now, but we're going to put a pin in that one until we get to that episode.
Our passion definitely matches, so I think we might get over into the weeds. We might need to stay on target.
That's right. I'm going to try to keep us on track here. So we're looking specifically at what are the unique reprocessing challenges in that ASC SPD. And to talk about that, let's start in that little closet that they call decontam in the ASCs. What's uniquely challenging about decontaminating in that space? And are there any hacks or tips that help people be compliant when you're trying to decontam in this itty bitty decontamination room when now we're doing robotics and orthopedic surgeries that are coming through there?
Yeah, the challenge is that you don't have the appropriate equipment installed in those facilities to do the work at the best and the highest possible quality, right? With the best quality, right? So most surgery centers, you might have one washer. And then that washer is also used to wash the rigid containers as well as the instruments. Some of the ambulatory surgery centers don't wash the rigid containers. They wipe them out and reuse them. So you have inconsistent processes because you lack the equipment necessary to render all instruments and containers and devices safe to use. Because of the demand for getting these cases done, the oversight in what is needed in sterile processing is often overlooked. I've seen it at literally every single ambulatory surgery center I've been in charge of. It is a small space. It was designed without sterile processing's input. So whoever these architects are is saying, hey, we built this, we can build it for you. But nobody ever goes back to research and say, hey, how is that working for you? You see what I'm saying? It is a very unique situation to get by with as little as possible. But what happens is that you are inconsistent with delivering the quality that's needed.
So I can, in some sense, understand that impulse of we want to spend as little as we can on the reprocessing area because that's not the area that makes the money. I'm putting air quotes up for those who can't see me right now because it's supporting surgeries. But it also makes me wonder at the same time, if we've been building ASCs like this for decades and folks like you and me, Monique, are saying it's just not working, or maybe there is research or data about the success of surgeries and the incidence of infections. I don't know. I haven't looked between an ASC and the hospital. Why hasn't that started to change? Do you have a thought on maybe why we're still having architects building ASCs the same way we did back when we were, as you said, just doing simple nip and tuck surgeries at the ASC?
So Nobody really makes big changes, boldly makes big changes, unless they're cited, unless there's a problem, unless you wind up with infections, and unless you wind up with a regulatory coming in that you've invited to say, hey, you can't have this anymore. I'm giving you 60 days, 6 months, 1 year to fix it. Then executives just don't make moves. If you don't have the volume of infections that's coming, then you say, why make the change? It's unfortunate that we're reactive people. We react. We're not forward thinking and forward planning. We are reactive, right? If it's not broke, don't fix it. And that's the problem. And then that happened. I'm going to circle back to the world of endoscopy. That mentality was happening in the world of endoscopy. And I don't know if you remember, it's got to be probably about 15 years ago, hospital, I think it was in Texas, a patient got deathly ill because of poor endoscope reprocessing. And at the time, ISHM, then HSPA at the time, every single conference, that's all we were learning about was flexible endoscope reprocessing. It was borderline egregious. We were like, what are we doing here? We do more than flexible endoscopes. Now you see flexible endoscope reprocessing at the highest standard. In any regulatory agency going into any facility, guess what they want to see? Your high-level disinfection process. They will laser focus on that above everything else. And so not until we wind up with serious situations, I worked for a healthcare system, one of our country's major healthcare systems in the United States just a year ago. And they had to shut down 2 of their sterile processing departments within 1 year, 2 different states. And now they're being proactive. You see? And so they're putting millions of dollars into fixing. I'm in the Northeast right now, and this healthcare system, I'm so proud of them. I'm an interim director supporting their initiatives to change, but they're not waiting. And this is the reason why I chose to help them. They're not waiting for some major event to happen within their state. They are working now, spending millions of dollars in sterile processing to get it to where it needs to be. Listen, surgeons are interested in what the sterile processing department is like before they come to your facility. Surgeons are getting really smart. They're graduating from fellowship and they're saying, how is the sterile processing department? They're not just coming in the door anymore asking for, I want this equipment. They're saying, can it get sterile?
Mm-hmm. Are they going to take care of me
problems?
here?
Yes.
Yep. Am I going to get handed impactors with bones still in it and things like that?
On.
For sure. Yeah, yes. I hear you. All right. So as we're talking about ASCs here, we've covered kind of the staffing piece of it. We've been talking about the space constraints and the financial constraints. There's one more piece that I want to cover before we wrap this conversation, and that has to do with quality management. When I worked in a really small sterile processing department, now mind you, it was just a small rural hospital. It wasn't an ambulatory surgery center. I really felt the squeeze in that department of each person kind of being their own quality checker. You know, when you work on a big team, there's lots of opportunities to have maybe that QA tech checking the trays, going back, reading through the sterilization records and checking your case cards to make sure those have been pulled appropriately. It's really challenging to do that quality management piece of it well in an ASC. I'm curious if you've seen anything that works well for small teams like that to be able to have what they would call a quality management system.
Let me tell you, I tell you, I've only had a couple of incidences where I managed that was not in a hospital setting. So when you're an ambulatory center associated with a healthcare system, associated with a hospital system and not a surgeon-owned system, infection control and quality are all over the place. Okay. And so you have that double check. But let me tell you what happens. Quality and infection control are not in your day to day. And many times, because of the limited staffing in ambulatory surgery centers, you are your decontaminator, you are the assembler, and you are the sterilizer. So it's kind of hard to check yourself because we all are high-minded when it comes to our own work. We said, oh yeah, I don't need to inspect it. I decontaminated it. right? I'm the one sterilized it. I don't need to go back and check. I did it myself, right? And so you have a superiority complex over your own processes, and you tend to think that you're flawless, right? It is always good to have a practice where you have a double checker, right? Somebody that's in the OR that can come and check behind the work that is being done. The problem is that the quality checks and inspections that take place in sterile processing are unique to sterile processing. So if you don't have the knowledge of sterile processing, how do you know that the biological is passed? How do you know that this is safe to use? How do you know that the sonic is working if you've never done a test on it? You see what I'm saying? How would you know to even read the results if that was never your experience? So I would say that just like ambulatory surgery centers hire regulatory agencies to come and help them, they should consider hiring consultants to come in quarterly just to do quality rounds. That's an investment that can be given that you can have on your books to say, hey, we have our sterile processing quality inspected every quarter, and we know we have safe practices. And this is an outside, not just your regulatory every 3 years. This is once a quarter.
Right.
It's worth the investment.
I think that's a wise idea of having somebody with fresh eyes to be able to come look at it, because fish doesn't know he's wet. So, you don't know what your own problems are. Sometimes it can be helpful to have that outside perspective.
Yes.
The other thing that I would add to that, as you're thinking about quality management systems, are there anything that are tests that are either, black and white that you can put in place that aren't dependent on speculation, that you build a policy around, and the policy guards the quality? So one example that just comes to mind immediately are cleaning verification tests. Maybe one way to check whether or not we're doing a good job in decontamination is requiring a certain number of cleaning verification tests to be done on the instruments, and record the results of that and turn that into a quality or an infection preventionist. And that way the data is kind of guarding the quality, even though you don't have another person there to be guarding it for you. And to the degree that we can do those types of things, making sure that systems and policies are protecting the quality, that can help maybe move us in that direction of having a quality checker or a quality assurance technician. But anyway, that's my 2 cents on that piece of it. Monique, really good interview. This time always goes by so fast. Really enjoyed the conversation around ASCs, particularly your passion for the industry that you bring to every conversation. I appreciate that. I've got some thinking to do more on what needs to change in the culture of healthcare delivery for sterile processing. How are we going to get to that place without a patient dying to start building out SPDs and ambulatory care centers the way that they need to be built? So anyway, thank you so much for joining the show today. Great job. Great conversation.
It was my pleasure. Thank you for having me.
That was Monique Jelks, Interim Director of Sterile Processing out in the Northeast, sharing her years of wisdom and her passion with us about the unique sterilization challenges in the ambulatory surgery center environment. And if you are still listening with us and you've not worked in an ASC or aren't working in one now, maybe don't even plan to work in one in the near future, I hope that this has been a helpful episode for you, because even though there are some unique challenges to that ambulatory surgery center environment, there are some things that we can learn from this discussion about instrument reprocessing in general. One in particular that I want to underline is Monique's dealing with the problems and challenges with being reactive, of only dealing with a problem once it's caused an event or it's been cited by the accreditation surveyors, and how much grief we could save ourselves if we are more forward thinking, if we're putting the investment on the front end, if we are creating quality systems to address the problems before they end up impacting a patient. So to the degree that all of us are able in our departments, let's be raising the quality of instrument reprocessing to the highest degree that we are able, what's within our scope of control. As we talked about quality management systems there at the end, what are some of the things that we can do to ensure that every patient gets the same quality of care, every instrument, every time that comes through our hands? How can we make sure that every patient, whether they get the care done at the hospital, at the ambulatory care center, at the outpatient surgery center that's just part of the same building as our hospital, no matter where they're getting their care, that they're getting that same quality of care from every provider, from every instrument that leaves our hands? And I think that's a good spot to wrap our conversation today. Thank you for tuning into this special series. We'll leave you as we always do here at Beyond Clean. Until we talk to you again next time, keep fighting dirty.